Right, welcome. My name is Dr. Nick Thomas. I'm the clinical lead for research at the Royal College of General Practitioners, and it's my absolute pleasure to introduce this session this evening on behalf of the Royal College about the RCGP Research and Surveillance Centre, otherwise known as ORCID, which we'll go through that in a few minutes' time. But first of all, really, it's around welcoming you all this evening. If you've got any questions and questions for us, please put them in the chat, and we'll come to them at the end. Thoughts all the way through are very welcome. Please again add them to the chat, any comments, and we will certainly absolutely come back to those. And any questions that we can't answer this evening, what we'll do then is contact you afterwards and certainly come back to you with those as soon as possible after that. Right, moving on. So yeah, the RCGP, as you know, we do a lot for research actually, and I want to sort of inform you and just sort of really focus minds again around what does the RCGP do for research? How does it support research? Well, it does this in many ways. There's the Research and Surveillance Centre, which we'll hear about a lot about very shortly. Obviously, we support Research Ready, of which we have so many practices across the UK who are research ready, who are participating in research, running their own running trials and supporting research delivery with our colleagues, the NIHR. We have the Scientific Foundation Board. Really important element here is to support new academic research, and that's the key to the Scientific Foundation Board, is to fund new academics who are really starting that journey to become senior great academics, of which we have so many across the UK, and we're so proud to be part of that. If you speak to the senior academics, most of those have actually been through the SFB many years ago, and we actually had some funding 20-30 years ago, which is amazing to hear. So some great stories with that. We have the Research Engagement Hub. Our Research Engagement Hub is a great piece that you can use to really engage and enthuse and sort of really try and work out, what do I need to know? How do I become an academic GP? How does that work? Well, actually, go to our Research Engagement Hub and it's all there, regardless of what stage of your general practice career you're at. We've got something there for you. We have our awards. Of course, the Research Paper of the Year, that we're very esteemed, they're very highly acclaimed awards with our outstanding early career researchers, and then our Practice of the Year, and also our first 5 Research GP of the Year. These will be at the winners' enclosure next week. I'm very proud to say at our annual conference, and we certainly look forward to finding who the winners will be there. We work very closely with our partners and our stakeholders, SAPSI, of course, the Society of Academic Primary Care, the School for Primary Care Research, and the NIHR, of course, amongst many others from CPRD, EMIS, and all of our other healthcare sector partners as well. And so, right, and then of course, bringing us on, we work with UK HSA. Well, how do we do that? Well, we work with them through ORCID and the RCGP RSC, and so we'll talk about that now, if that's all right. Moving on, Lottie, if that's okay. So, what we'll cover in the webinar this evening, you'll hear certainly not only from me. I'll be very brief in this little part, because actually you want to hear about the RSC and how does that work, and how can you be involved, what can I do to be part of it, and also what can it do for me and what can it do for my practice. Well, actually it can do a lot, and it certainly does a lot, and so we'll cover all that for you this evening, if that's all right. Next slide, please, Lottie. Thank you. And so the other importance, I thought I'd just float for a second, really, is around what does the RSC do for the college? Well, actually, being engaged with the RSC, supporting the RSC, which you will find out the history of that as we go through this evening. But actually, it informs us so much on our policy work within the college. How are we able to work with government? How are we able to lobby on behalf of our members? Well, actually, that's through a lot of the information that we get from the RSC. So it's really important to cover that and sort of discuss that this evening, if that's okay. I'll have a word from our chair, Professor Camilla Hawthorne. Let's go.
Hi everyone. My name's Camilla Hawthorne. I'm chair of the Royal College of GPs and a working GP in South Wales. To those not familiar with the RSC, the Research Surveillance Centre, this will be an introduction and to the wide range of work that it does. To those who are currently involved in the network, this will be a refresher and hopefully an insight on how to get more involved. Although much of the RSC's work happens behind the scenes, its comprehensive monitoring capabilities allow for early detection and prompt response to any resurgence of respiratory viruses, which is especially important in the winter seasons. This was particularly important during the COVID-19 pandemic, where the RSC played a crucial role providing invaluable information about the spread of the virus across the country. The RSC supported many investigational trials through the pandemic, informing many key decisions, including those on vaccine effectiveness and virology surveillance. More recently, during the last winter season, the RSC monitored the spread of strep A across the nation, further exemplifying the value of this network. So I'd like to encourage each of you to consider signing up your practices to become part of this network. By joining the ranks of GP colleagues who already share their data with us, you'll help to enhance the accuracy of our information. On signing up, you'll gain access to a dashboard that displays the diseases currently circulating within your community. Additionally, you'll have the opportunity to actively participate in our sampling program, which has two arms, serology and virology sampling. Taking part in these programs could also provide you with a chance to earn some extra income. The serology aspect involves taking an additional blood sample from patients in your practice, while the virology component is just a swab sample that can be taken in practice or by the patient at home. We're hoping to collect 1,000 samples per week to ensure a representative sample of the population. I urge each of you to seriously consider becoming part of this crucial initiative. Your involvement will not only benefit your practice, but also contribute significantly to the collective efforts in understanding and combating communicable diseases. Thank you for your attention, and I hope to welcome many of you as valuable contributors to the RCGP Research Surveillance Centre, the RSC, in the future. Thank you again.
Hawthorne, obviously the chair of the RCGP, and absolute pleasure to listen to Camilla there speak about the RSC. Right, without further ado then, let's find out more about the RSC, shall we? We've got Professor Simon de Luisgnan coming at the end, and last but not least, it'll be Simon then speaking to us mainly more around the RSC. But first of all, let's hear from the really important parts of the RSC as well, who's our practice liaison team. And so I'll pass you on to Lizzie, and Lizzie will tell us more.
Super, thanks very much, Nick. My name is Elizabeth Button. I'm part of the practice liaison team, and it's my pleasure today to be presenting alongside my colleagues, Ash Sexton and Jess Smylie. We're going to do a little bit of a deep dive into what Camilla has already mentioned, namely the contribution that practices make through data sharing. And our focus today really is going to be on the virology sampling. Do you mind going back a slide? Sorry. Just to say that you'll be seeing our email here quite a lot throughout this presentation. If you're not already signed up to our network, do drop us a line, do drop us an email. Sign up is very easy. It's a very quick process. There's a couple of data sharing agreements, and the onboarding for our virology sampling is also very simple. Thanks, Lottie. Great. So who are we? We are one of Europe's oldest general practice sentinel networks. We have been conducting disease surveillance for over 60 years. We currently have nearly 2,000 practices in our network across England and Wales, which represents around 19 million patients, which is about a third of the English national population. As well as the disease surveillance that we'll be talking about today, we also support ethically approved health research, many of which of those studies are included on the CRN portfolio. Practices that are part of our network also benefit from the support of a dedicated practice liaison team. And just to say that we're also this year looking to get more involved with patient participation groups. Next slide, please, Lottie. So the data that practices contribute, being part of our network, creates a really unique data set. But why is it so special? Well, firstly, it's special for its freshness. The data that is extracted twice a week provides almost near real-time data, which can really help to support early detection systems. The quality of that data is also very high, and it's also data that we can link, so, for example, to secondary care data. So that really allows us to characterize more vulnerable populations, people in clinical risk groups, for example, people with diabetes, people with chronic conditions, or the immunosuppressed. And another really big benefit is that this data set is broadly representative of the national population when compared to national statistics in terms of things like age, gender, and ethnicity. So it's a really, really valuable and powerful resource. Next slide, please. So obviously it's important to make mention of who's involved, and Nick has already introduced this. Since 2019, the RSC Research and Surveillance Centre has been run as a collaboration between the Royal College of General Practitioners, the UK Health Security Agency, formerly Public Health England, and the University of Oxford. The ORCID is the name of our digital hub, and where the data is held, and that's hosted by the Nuffield Department of Primary Care Health Sciences here at the University of Oxford. And now I will be passing on to my colleague Ash.
Thanks very much, Lizzie. Hopefully you can all hear me okay. So I'll start with going into a little bit more detail on how data is used. And I just wanted to start with a quick kind of slide about the importance of practices' involvement in disease surveillance. So we rely on practices to conduct the surveillance that we do, and this involves supporting and collaborating with the UK HSA to conduct surveillance, helping to inform the health service of imminent problems. Our work also feeds into monitoring the spread of viruses over time across age groups and in different regions. A key element of the work that we do helps to establish vaccine effectiveness for each winter season, and ultimately this information all feeds into decision making that is done by the World Health Organization. So in terms of the kind of how practices can participate in the network, there are two main elements really. So the first one is contributing routine patient data from the practice, and secondly, active participation through the collection of virology and serology samples. So I'll start with the first one of these, the data, and then I'll hand over to Jess to talk about the virology sampling. Can I have the next slide, please, Lottie? Thanks. So in terms of using data from practices, so the data that we hold in the ORCID database is de-identified, so it's not possible to identify any patient from the data. The data is broken down by region, age group, and disease type, and you can see an example of one of the graphs that we have, and this is showing the number of sore throat strep infections here, and this relates to what kind of Camilla mentioned at the beginning, in that the network was really important in identifying this increase in the kind of prevalence of strep infection in the last winter season. So in terms of sorry, could you go back? Yeah. So the data that we collect also feeds into the RCGP weekly reports, and this report presents data on 37 different conditions, including flu, COVID-19, and RSV. And just going on to the next slide, please. This is just a quick slide to kind of show the different conditions that we report on, so you can see it's quite an extensive list here. And then next slide, please, Lottie. So to give you a bit more detail on how the data flows within the system, so we collect data from three main sources. The first one is the data from the routine patient records in the practice. Secondly, we get data from the virology and the serology sample results, and the third source is the linked data that we use. So, for example, secondary care data relating to hospitalization. So data from all of these sources is pseudonymized before it is held by us within the ORCID database at the University of Oxford, and the data from the central database then feeds into the surveillance work that we do, as well as other research output as well. Next slide, please, Lottie. Thanks. So yeah, just to give you a little bit more detail on the pseudonymization process. And so on the left-hand side here at the top, so we have the primary data collection box, And you can see here there's a representation of a patient record which has an NHS number. You can see that this gets converted or scrambled using a one-way encryption method into kind of a hashed NHS ID. And a similar approach is used with the linked data, where this NHS number is again scrambled using the same algorithm here to encrypt the data. Any other identifiers are also kind of made so that they can't be used to identify a patient. So, for example, the date of birth is rounded to the first of the month here. And then this data can be linked up based on the scrambled NHS number. And then there's a further step to promote data security, in that the hashed NHS number is converted to an ORCID patient index. So anyone who is using this data within the secure environment would never have access to the hashed NHS number. So that brings us to the end of the kind of looking at the data side of it. So I'll hand you over now to Jess.
Hello. Okay, virology sampling. This is our bread and butter. This is our core piece of work, and what you'll be hearing a lot about from us if you decide to join the network. So focus on virology sampling. The network contributes towards yearly influenza virology, or has done since the 1990s. The samples allow us to monitor the spread of respiratory infections and measure vaccine effectiveness. There's going to be a lot of hopefully new vaccines and therapies coming out for RSV, COVID-19. So it's really important that we get as many samples as we can to contribute towards this work. You'll see the lovely little image at the top there, about 1,000 swabs. This is a sample size calculation that we believe we need from the entire network. Please don't worry, it's very easily done. There's a nice little graphic there that shows the number of samples by virus by week. And you can see there that lovely little spike between October and April. And that is what the data contributes to. Next slide, please, Lottie. It's a lovely little picture of our medical director there. So there are a couple of ways in which practices can provide swabs for us. So you can do the in-practice route, which is if you're a clinician doing face-to-face consultation, you can take a virology sample using one of our in-practice kits, which I will show you in just a moment. Or you can, if you're part of a triage team doing online or over the phone consultations, you could direct your patients to a service called Take a Test, where you would send them a link to the website with your ODS code, and they can request a kit for them to self-swab. I'll also be showing you that in just a moment. There are variations on this depending on how your practice runs and which team members are likely to get involved, but it's very easy to integrate into your day-to-day workflow. We are here as well to support. The PLO team are here to support on a daily basis for any of your needs, training, guidance. We'd really love to know about any motivators and blockers that you have to carry out this work and see if there are ways around them. Next slide, please, Lottie. So we have two kits here. The first one is the in-practice kit. This is our standard one. So if you order one of our kits, you can receive, you expect to receive a specimen tube with 2 swabs. It's ideally one for the nose, one for the throat, but if you have a patient that can't deal with anything in the throat, you can do one in either nostril. They would both go into the same specimen tube, which then goes into the provided transport tube that way. In the kit, you will also find information leaflets on how to take the swab, though everyone must be a seasoned professional by now. Information leaflet on how to post the entire sample. There's a patient information sheet, which is very important. It explains to the patient who we are, what we're doing, why we're doing it, what happens with their sample. Very important that they read, understand, and verbally consent. There is also a prepaid envelope to our designated lab and a lab form, which would need to be completed and posted off with the kit. That is the in-practice one. And like we say, there is another option for Take a Test. It is essentially the same kit, but it is online. The patient will complete the lab form themselves. This kit will go to their house. They will self-swab, send it off to the lab themselves, and the results will be returned as they would with the in-practice kits. There is quite a process involved with doing this. There is an element of coding. There's obviously the consultation. You need to code everything that happens, all the symptoms, we have a new person, just admit them. Code the symptoms, code that a swab is taken, and you would code the result when they come back in. Okay, if we can jump on to the next slide, please, Lottie. Perfect. So practice expectations. We are asking that practices swab any patient, regardless of age, gender, anything like that, who are presenting with symptoms of acute respiratory infection within 10 days of symptom onset. It's very important. Like I say, we ask that you code as many of the symptoms or examination findings as possible. Again, if you join our network, a lot of the comms we send out will carry the message, coding is caring. That is our mantra. We're looking for a minimum of 20 samples per week or more if you have a large practice or, quite honestly, an unfortunate practice population. And just to the side there, you'll see an example of the guidance that we send out to practices for this work. These are our main conditions of interest, so influenza-like illness, exacerbation of chronic lung disease, lower respiratory tract infection, and upper respiratory tract infection. Next slide, please, Lottie. So the benefits of taking part, there are many, so we've just listed a few. So it makes a difference towards the public health surveillance. Virology sampling is a very easy introduction to participating in other related research studies that we carry out. You'll find quite a lot of them do revolve around taking a swab. You receive results for a range of viruses. It's not just flu, COVID, RSV. You'll see things like adenovirus, enterovirus, rhinovirus. The list goes on. Virology sampling can help reassure and provide feedback to patients, which may help support the practice decisions around antibiotic prescribing. This is a very common piece of feedback that we receive from practices. Patients feel more listened to, more cared for, and they go home happy, despite potentially symptomatic. Practices are reimbursed for every sample taken. It's currently £12.50, though this is under review. It's great to boost morale and motivate the team with incentives and competition within the practice. There's a sort of Hunger Games style competition that goes in quite a lot of the practices. Nick himself does it, so I'm sure he's aware. And practices find their own ways of making this fun, which sounds quite odd, but it works for them. You can also utilise bespoke practice level dashboards to see what viruses are circulating in your community. Next slide, please, Lottie. Dashboards. So we provide a number of dashboards to support surveillance and specific research studies. So we're going to focus on the virology dashboard, as that's what we're discussing at the moment, though there is one available for serology. The virology dashboard can be used to monitor the sampling progress and encourage participation in the practice. Again, a lot of practices will use the dashboard as part of their incentive or competition that they've set up. So each practice will be issued with a designated practice key, which they're the only ones that control it, they're the ones that have access to it, and that will show their particular practice data. So when you first enter the dashboard, you'll see the RSC as a whole. You can then zero in on your own practice to have a look at things like the number of swabs by week and where those little lines are. If you hover over them in the dashboard, it will give you a further breakdown of the information. And again, another one, percentage of positive samples by week. You can see there it's broken down into the individual viruses that we test for. Next slide, please, Lottie. This is where I'll hand over to Ash.
Thanks, Jess. So here we have a testimonial from one of our top performing GPs, and they're based in Woodstock Bower Practice, which is in Rotherham. And here they share some of their experiences of taking part in the network, as well as some tips for other practices. So,
good evening, guys. I'm Dr. Hussain. I am a GP partner at Woodstock Bower Surgery in Rotherham, and we joined the surveillance programme back in March 23. Our motivations for joining the surveillance programme were because we are in quite a deprived area in Rotherham, and our patient population is quite a demanding patient population, in terms of wanting antibiotics at the onset of coughs, colds, runny noses, anything along those lines. A patient could have had a sore throat for a day and be demanding antibiotics. And because of this, we wanted to join the programme kind of to gather evidence of the infections going around our area, in order to use these as evidence in the future. When we saw our patients, we could actually tell them, guys, your last infection was this virus in particular. It was not a bacterial infection, and therefore you've presented with similar symptoms, and therefore just like the last time you might not need antibiotics this time. So that was our motivation for joining the surveillance program. Since we've joined, we've absolutely loved doing it. Whenever we don't give patients antibiotics, if they've got a viral upper respiratory tract infection, we do the throat swab, and the patient feels like something has been done for them instead of antibiotics, for example, and it's helping us to steward our antibiotic prescribing as well. Now, some of the top tips that we have for you guys who might be embarking on this journey are, number one, just integrate it into your day. So I will start off with a pile of swabs on my desk, and then if a patient comes in with the relevant symptoms having started within 10 days, what I'll do is I'll just get a swab, I'll consent the patient, take the swab, throat and nose, and then just write it up at the time, fill in the form. In total, that whole process takes me about a minute now. Do the correct coding, all of that takes about 60 seconds, so it's not much of a disruptance within my day. And then at the end of the day, we'll go and post the swabs. What I do recommend is having everyone in your practice on the lookout for these symptoms. We kind of like to be fully engrossed in research, so let's say our pharmacy ACP sees a patient with a cough or a cold or fever that started within 10 days, they know to do a swab, and they know to write up the research paper as well. Within the blood surveillance, the way we've incorporated this into our practice is we have hired a phlebotomist, we have taught them how to consent patients, and once we receive a batch of blood tests, such as 50 blood tests, we'll just pop them in the clinic. Every other patient will ask them to consent and get through the 50 bloods until we get the next batch. And that's again been not disruptive to the workings of the practice at all.
Thank you.
Thank you.
Thanks, Lottie. And we do also have a range of tips from our other practices as well, which we're very happy to share with anyone wanting to sign up. If you could just go to the next slide, please, Lottie. Okay, so just a quick note really on some of our patient and public involvement work, and we're increasing some of this work in the upcoming season, and we're really keen to engage and involve patients from our practice PPGs, both to gain their views on surveillance as well as some of the linked research that we do. So we hope to increase awareness of surveillance in the public, including how patient data is used and how we can improve its acceptability to patients. We'll be launching a patient and public newsletter this month, and we're really keen for any practices to get in touch if you would like us to come and present at a PPG. And I've just included an image of our poster, which is designed to be displayed in waiting areas, and this is to invite patients to get in touch with us and to get any opportunities to get involved. So I think that brings me to Lizzie, who's going to talk a little bit about some of the research studies that we do.
Thanks, Ash. Yeah, just to make mention, obviously, in addition to the surveillance work that we really encourage all of our practices to participate in, we also host a number of research studies that practices can choose to participate in as well. These are a range of mostly observational, but some interventional studies as well, and many, as I mentioned earlier, of which are included on the CRN portfolio, which means that the practice has access to additional funding through your local clinical research network. Next slide, please. So yeah, this is just a snapshot of some of the current and previous studies that we've run and are currently running. At the moment, we are running a number of point of care testing studies to really better understand how point of care testing can be integrated into primary care. We're quite excited about this. We are also running a stool sampling study, the IID3 study, which is looking at the patterns of infectious intestinal disease in the community. It's also sort of a foundation to some surveillance work there. And we have some quality improvement studies as well. The monetary study, for example, is exploring whether web-based education tools can improve medication prescribing in certain patients. Yeah, and other studies that we've run in the past, you may recognize the principal study, obviously looking at medicines to help people with COVID-19. We've recently finished the RSV ComNet study, which was looking at the clinical and socioeconomic disease burden of RSV in children as well. So yeah, that's just a snapshot. If you're interested in any of that, again, get in touch with us via our practice inquiries email. Thank you. Now I'll pass on to our director, Professor Simon de Luisgnan.
Good evening, everyone, and thank you very much for joining this meeting. I guess I just wanted to give a brief summary and overview of the network's activities, and fantastic if anyone who is on the call or listens to this webinar gets involved. In summary, I'm very interested to have more network members. We think a really good way for health data to be shared is through bottom-up, professionally led networks. And as has been said, what's unique in our network is our direct connection with the practices who conduct sampling, and of particular importance is virology, and collect other data. As a network, we have great data quality, especially for acute infections, and our main network activity is the monitoring of influenza, COVID, RSC, and other respiratory infections, though we do have a wider surveillance. And as has already been mentioned by our college chair, we were the group that monitored that streptococcal sore throat before Christmas 2022 was the highest ever, really, with the previous high peak being 2014. And this is something that's fantastic to be part of. In terms of us putting in that problem title, we're really keen. If you think someone's got flu, you label them as a problem, as an influenza-like illness. If they're an exacerbation of a chronic lung disease like asthma or COPD, it's recorded as a problem. Or if we think it's a lower or upper respiratory infection, diagnosed as specifically as we can with an advance of probabilities. That's really great, and it helps us link a disease to virology. Two of the diseases we link best are influenza-like illness and a positive influenza swab. And in our network, roughly half, sometimes years it's 56%, some years 48%. Half of the people that GPs in our network diagnosed, and it's probably GPs everywhere, but the virology isn't measured. Half of the people that GPs measure as having influenza-like illness actually have positive flu virology. The other area that is really interesting is where GPs in the network diagnose acute bronchitis or bronchiolitis in the under fives. Between 40 and 50% have RSV, with another 40% roughly having rhinovirus. So these things are really interesting. And as the school term goes back, we see adenovirus peaking. This year it was adenovirus and COVID, but when adenovirus peaks, we see back to school asthma. So all these virological insights that we provide, I'm really keen to see people, as been described, taking virology samples in consultation. And we also have kits that can be sent to home if you're doing telephone triage or telephone consultations. We hope that there's, beyond being part of this exciting network, other rewards for participating practices. We do pay practices per sample, has been said, and I think the median earnings of our top 10 sampling practices, virology sampling practices, is over 5,000 a year in terms of earnings from their virology sampling, as well as getting for themselves these disease insights. And also, was alluded to on the video clip, there are definitely some associations between practices that are involved in virology and good antimicrobial stewardship. And there's another context that always amuses me when someone comes back to complain their antibiotics haven't worked, and you've had the virology swab through showing a viral diagnosis. It perhaps helps manage that situation too. We hope being part of this network, for those who are interested and those of us involved, has some societal benefits in terms of monitoring the spread of disease, and particularly vaccine effectiveness, and particularly our ability to assess new therapies. And although we're still on a learning curve, point of care tests, where you do a swab which you cook in a machine for between 20 and 30 minutes and get an instant virological answer as to whether someone's got flu, COVID, RSV, etc., I think will become more and more important in primary care, and particularly people from vulnerable groups who need to start on antiviral therapies early in the course of illness. It would be really useful. I'm going to finish with a couple of pivotal moments from the RSC over the course of the pandemic, which I'd like to feel reinforces the value of the work our network does, and how grateful we are to colleagues who get involved. The network actually had on the 28th of January our first COVID case, which was pretty much the first COVID case. But much more important was when our practices, one in Hazelmere and then a week later in Edgbaston, detected COVID for the first time in someone who'd had absolutely no personal or family connection with overseas, that really indicated that COVID was spreading in the community. And the idea of being a sentinel network is being a sentry, someone on watch. And this was a real, these were both really canary in the mine moments, which said that community spread was inevitable. Two big examples from serology was we started doing serology at scale during the pandemic, sometimes nearly up to 2,000 samples per week. And this really showed that there wasn't the background immunity. Although the COVID virus spreads rapidly, wasn't the background spread going on that meant the population was going to be immune without really a population level vaccination program. And the work of the RSC wasn't the only work, but it was a really, really important piece of work in that regard. And a second serology example is that people, for example, with methotrexate might come back to the practice and have several serology samples. And from monitoring particularly the immunocompromised groups, so those immunocompromised, solid organ transplants, recent solid organ cancers, etc., the network was really able to show how quickly vaccine waning took place. And again, a lot of work by a lot of people, very pleased to be part of the decision being made about how soon boosters had to go to those risk groups. So that's where perhaps we've had to really go for it a bit at an unexpected time. But overall, it's a fantastic network to be part of, and we would welcome any other colleagues who would like to get involved. Back to you, Nick.
Thanks, Simon. Actually, I think it's on to Lottie next, is it? Lottie, if we do the question, one of the questions, is that right? Simon's done the big push to try to welcome people to the RSC, which is obviously fantastic, and thank you for that. I'll just quickly summarize again, if that's all right, guys. It's very, very easy to take part, very easy to be part of it. I know Dr. Hussein's obviously his report was obviously fantastic, and we can only thank him for taking part in this. And over to Lottie for any questions, Lottie.
Hi everybody, my name's Lottie. I'm the Research Projects and Communications Officer at the college. And yeah, I just want to open the floor up for any questions. You could either put them in the chat or if you'd like to raise a hand, feel free to. If not, I'll kick off with a couple of questions. Nick, you just said that you said it's very easy, but for practices who are not currently part of the network, how quickly could they get up swabbing? I think it's a key bit of information people would like to know.
Great. Well, I think I'll get Jess to talk about that one. Jess, can you come on and just give us a brief chat about that? Thanks, Jess.
Of course, for any practice that wants to join the network, there's a process that we go through. So practices are asked to sign 2 sets of data sharing agreements. There's one between the university and the practice itself, which is saying, yes, we're happy for the university to extract and hold our patient data. There is another one between the practice and our third-party data facilitator, which they're called Magentis. So depending on which system you run with, if it's EMIS, it's as easy as once the agreements are signed, it goes to Magentis and they will contact you and ask you to click a button for EMIS to turn on that extraction. If you're a TPP system, slightly more difficult process. It requires a dial-on. So as long as you're available for that dial-on, as soon as they are able to get hold of you, they will get that extraction set up. So the first step is signing those agreements. Then we would want to have a call with you or a practice visit, which would be great to see you in practice, visit the rest of your team to run through the requirements, benefits and process of taking part in the virology sampling, swabbing, the serology sampling, depending on which one you would like to get involved in. Then it's a case of, if it's serology, you can start immediately. If it's virology, a couple of admin points, getting a lab form and a lab code for you, signing you up for the Take a Test service, which we would highly recommend. It's a really great and useful service for practices. Once that's all done, you are free to start.
Thanks, Jess. I think that all sounds like a lot, and it's like, oh no. But actually, it doesn't take long at all. Actually, it really doesn't. And our super practice liaison team are able to hold the hands through it all the way, because if I can do it, our practices can do it, then I think anyone can do it in that respect. So thanks for that, Jess. Lottie, any other questions?
Yes. So I think Dr. Hussein sort of hinted at it, and it was mentioned on Simon's slide. But I was going to ask how much of an impact has the RSC made on antibiotic stewardship?
Simon, I think we'll come back to Simon for that one, definitely.
You definitely can see a difference, and I think it's fair to say there's an association with antimicrobial stewardship, but it's always very difficult to, if you like, without more modelling and analysis than we have done, to say, you know, we've got a high level of evidence for that. But both anecdotally and also where we've looked at testing and antiviral use, our practices, if you do simple statistical models like test of proportion and things, you can easily get a sort of tiny p-value that there's a strong odds ratio towards less antimicrobial therapy and greater use of antivirals. And it's not as I say, all singing or dancing model or analysis that leads us to that conclusion.
I think also, Simon, isn't it, that our patients respond to this extremely well, as Dr. Hussein was inferring as well, that actually patients engage with this, they take ownership of this, and to find out what that virus was that they had. Actually, yes, the result comes a week later, but actually it's fascinating for them to really find out and go, actually, that's great. Therefore, they know what happens next time, and they know, we all encourage patients to take care of their health, to look after themselves, take ownership of their health, because that's obviously vitally important to us going forward. Great, thank you. Lottie, are there any further questions?
I would, if anyone else would like to add another one, like, more than welcome to. But I was just going to say, if you don't, practices don't have to contribute to the swabbing. That's another thing I think to add. Just I don't know whether someone wants to jump in and say, you know, just contributing, if just contributing enough isn't, just contributing by signing up is enough.
We're delighted if people want to sign up and do data sharing, and if they see a particular study that appeals, then that's great. We do all work very closely with the CRNs. There often tends to be quite an overlap between CRN active practices, and there are some CRN studies that, if you're an RCGP member and reasonable data quality, are easier to get involved with. If you want to go for the full Monty virology, I can't pretend I won't be very pleased. But there it is. If I may just, Nick, if I may rude, just nip back to one of the earlier points you made about the sampling and virology. And that is, I think up until the pandemic, a lot of people were happy for me to say it must be a virus. And since the comprehensive population-wide testing in the COVID period, I find people want to know. And before the pandemic, 8% of people, 5% said, oh, I gag, I don't want to swab. Now no one says they don't want to swab. We're all swab tolerant. And as a society, I think we want to know the answer. What is this bug?
Absolutely, that's exactly how it works. And then, regards to Lottie's point, then really was that yes, you can engage with the RSC. You can be a member of the RSC. Doesn't mean you have to be that active right now. We all understand the pressures that are under general practice right now within our members, within our membership, my practice, everybody's practice. We all know that the sort of challenges that are going on within the NHS right now, and we understand that completely. And that's the beauty of this, is that, you know, when the time is right for the practice, then absolutely, you want to engage more, that's absolutely great. That's what our team is here to help. Our team is here to support, and our team is here to facilitate that, to really support you and help you and guide you through it. So even if that's, you know, we all know practices fluctuate with regards to challenges and pressures at different points, and so we'll just be very supportive with that.
That's great. Thank you both. Have we got any other questions? If not, I would just like to thank you all for coming. And remember, if you want to get involved, we'll be thrilled to have you, or the everyone at the Practice Liaison Officer team. Would be great to hear. Would love to hear from you. And they put their email. Lizzie, thank you for putting your email again in the chat. If you want to hear anything else from RCGP Research and Innovation team, you can contact us at research@rcgp.org.uk, and we'll be happy to help with any of your research queries. Please look out for our research communications online. You'll be seeing, as we amp up over Christmas, more and more calls about what the RSC is up to. Yeah, and thank you all for coming, and goodbye.